Now, my good friend, Rafael Sánchez Salas, can you connect him, please? Hola.
Hola, ¿qué tal?
No te escuchamos. Ahora sí.
Okay, perfect.
Okay, Rafael, thank you for being here. I know you're busy. You would love to be here, but you can't. But we appreciate, Rafael is president of the Focal Therapy Society, and they have a spot in this program. And we are very proud to say that he's supporting us. We are very, very proud, and we welcome this important society because focal therapy is in the eye of a storm, and we want to know what there's inside this. So let me tell you a little bit about Rafael. He's an associate professor of urology, Department of Surgery, Division of Urology, McGill University, Montreal, Canada. The podium is all yours, Rafael.
Well, good morning, everybody, and thank you. As you said, it's a pity that I'm not there. Thank you for the words toward the Focal Therapy Society. I'm not gonna talk. Not gonna address focal therapy in this talk. So we're gonna address the radical prostatectomy in high-risk prostate cancer. Is there a place for lymph node dissection? This is a controversial topic nowadays. So these are my disclosures. And as you know, high risk and locally advanced prostate cancer are a very heterogeneous aspect of prostate cancer. That is a fact, and the variations of clinical aggressiveness are several. Effective staging and stratification at this level is essential, so the therapeutical decision is the right one when it is chosen. And it's essential to understand that the novel imaging modalities have gained a space, a very important space in the stratification, and they have a tendency to change the way we look at high risk and locally advanced prostate cancer nowadays. So the definitions of high risk and locally advanced prostate cancers are variations, starting from the initial D'Amico high risk prostate cancer radiation. We all remember that the PSA higher than 20, Gleason higher equal than 8, or in a clinical stage or higher than T2, T2C. But then there's been an evolution, and you can look at even the EAU localized high risk prostate cancer, the Sunday very high risk prostate cancer. There are different variations, which gives you a little better idea of how heterogeneous this stage of the disease. So we're going to go through this clinical case, a 53-year-old man. There's no relevant medical history, just an uncle on the father's side with a history of prostate cancer, PSA of 5.6, and an MRI that is one of the first elements of imaging that actually change prostate cancer approach, the pathway. One Pirates 4 lesion located posterolaterally on the left side with a prostate of a 30 cc. So this man underwent a biopsy, a fusion biopsy with a transperineal approach. That is, personally speaking, is how we believe biopsies should be done, with fusion and in a transperineal approach that is related to less complications in terms of sepsis. So we found a Gleason 4+4. There was no cribriform pattern. And the question now is, which metastatic workup should we order? This is a high risk by definition. And we have the conventional imaging that we have all used for many years. And most recent, there is the PET scans. So when you look at the PET PSMA versus conventional imaging, this is a paper from Show, and it's a head-to-head comparison of the diagnostic accuracy of PSMA versus conventional images. So when you have a lymph node, you see that the PSMA has a sensitivity of 73% versus a sensitivity of multiparametric MRI that is 38%, so with a very high specificity. This is for lymph nodes. When you look at the bone, PSMA has a very high sensitivity and specificity that is quite higher than the one that is we can find in the typical way we have approached these patients, the bone scan. And in terms of the final pathology, PSMA PET combined with MRI has a very good predictive numbers in sensitivity, and both the sensitivity and specificity for um, um, the extracapsular extension and seminal vesicle extension. So we have a new modality that is giving us more information. So is PSMA PET should be the first line staging modality, not widely accepted in every association or every guideline, but it's probably what it should be done at least starting in the Gleason's of 4+3 and higher. When you look at the European Association guidelines for high risk, there's an indication strong rating for PSMA PET if available, obviously, when you perform the metastatic screening in these high risk patients. When you combine PSMA PET and a promise, is a way to redefine disease. So, because this classification will improve the staging accuracy compared to conventional imaging, there is more precise detection of nodal and metastatic disease, including micrometastasis, when at least 30% of patients that can be reclassified into a different stage, and that obviously plays a role on the treatment decision. So PROMISE is a standardized reproducible method for reporting PSMA PET for initial prostate cancer staging. We go back to the same situation that happened with MRI, in terms of we need to speak speak the same language, and PROMISE is providing that. It's a way to communicate effectively in terms of the information we are getting. So what do we do with what did we do with with patients? Given the result, the patient was presented. Treatment options were radiotherapy versus radical prostatectomy, and at this time we had a bone scan. So what is the value of intensification in these patients? We know that this is a disease that will eventually need multimodal treatment. So radical prostatectomy alone is rarely enough for high-risk de novo prostate cancer. 30% of these patients will benefit from surgery, but 70% of these patients will definitely need more for the treatment. So there's a neoadjuvant RP or ADT that's promising for down staging, as we know, but there is still data pending on the overall survival information. So obviously, we have the idea that there's SBRT plus ADT, and obviously the inclusion more recently of an RP improves the outcomes of after surgery. But PSMA will be a central piece of information to select who needs or not to be intensified in terms of treatment. So in terms that is for the radiotherapy side, where there are some arguments that go on the side of our surgical approach. So though being those cancer control, staging accuracy, the salvage flexibility. Now, obviously, we need or we avoid the indication of ADT and the quality of life balance after the procedure. So there's benefits and risks of primary treatments in high-risk prostate cancer. This is a systematic review from Lisa Norwich. So the optimal treatment, as you will imagine, is not clearly defined. There is a little bit of advantage for radical prostatectomy, although the evidence is very low, actually. And obviously, multimodal risk adapted treatment will be the best option for these patients. The patients need to be informed from day one that there's a high possibility of having multimodal treatment, and because that avoids frustration in the future. So both options are curative approaches, but optimal outcomes are rare. So if you try to go for one single option, so the patients will benefit from intensification in order to improve oncological outcomes. So RP, so radical prostatectomy, is part of the multimodal treatment, and it can be recommended as a primary treatment, obviously based on the information we just described. So what we did in this patient was a radical prostatectomy as an initial approach. It had a Memorial Sloan Kettering 10% risk of a lymph node involvement. So there was an indication for lymph node dissection. The question would be, do you need to do a lymph node dissection? And if so, which template is to be deployed? We had the discussions on the value of lymph node dissection. There is still controversy on this aspect of surgery, and this is mostly related to the fact there is comorbidity associated. When you look at the 2-year study from Memorial, it's a limited versus extended pelvic lymph node dissection, and this is the initial publication. It was a limited versus extended. It's hard to make the difference between 12 versus 14 nodes um, dissected during the procedure, but there was no difference on BCR-free survival. Complication rate was similar between two groups. You see the lines in the Kaplan-Meier; they're quite one above each other, so there's no clear difference. A more recent analysis of this study is showing that there is that extended lymph node dissection provides a protective, what they call protective effect. And the conclusion is that perhaps lymph node dissection may reduce metastatic progression at this point. This is a longer follow-up. It's a subset analysis, so not necessarily convinced about it. That they have really advocate for the benefits of lymph node dissection, which becomes difficult with the information we have from PSMA. But the initial results are showing the no oncologic benefit, although in the extended follow-up, PNLD has perhaps some protective effect, especially in N1 patients. So this is a piece of information that is essential because it takes us to the benefits and harms of lymph node dissection. We understand that this is a procedure that is associated with complications, and even if the patients do well in terms of cancer control, in terms of the benefits of the lymph node dissection that we see on the long term, there are complications associated like lymphedema and lymphocyte that are quite negative in terms of the impact on quality of life. So, would you do a lymph node dissection if PSMA is negative? There's this interesting study from Armando Stabili. So the diagnostic accuracy, sensitivity, and specificity is 58 for sensitivity and 95 for specificity, with a predictive values there shows 87 negative predicted value per patient, but we see there is still a miss in the number of micrometastases. So if you look at a risk adapter interpretation, negative PSMA cannot replace, at least at this point, a lymph node dissection. And the clinical message from this study is that PSMA refined gives more information, but at this time will not replace the guideline for lymph node dissection. So it's probably in line with the discussion, recent publication from Vickers and Touye that states that still a role for lymph node dissection, even if we have the information from PSMA. So in this work from Varis Essen, PSMA show a negative predictive value that is excellent. Before it's better than the one that we saw in the slide before. So but this findings support the omission of lymph node dissection in intermediate risk prostate cancer in PSMA negative patients. This is the other side of the story, is giving you the idea that PSMA can change the possibilities of indicating lymph node dissection of node. So in an integrated strategy, we should be not just look at one element, but risk calculators, prevalence, PSMA refines detection, multiparametric MRI improves localization. So it's the combination of all those that probably make the best decision making, rather than basing our indication in just one single variable. So we did lymph node dissection in this patient, 4+3. It was we did a radical prostatectomy. We found a 4+3 prostate cancer. Was cribriform was absent, no esophageal extension, negative surgical margins, and the lymph node dissection is just calling for 6 nodes, where it's not clearly defined as what you would call a radical, but still it's a PT2, a patient that was initially thought to be a 4+4 prostate cancer, something you have seen in many cases in your practice, I'm sure. So in conclusion, high risk and locally advanced prostate cancer require multimodal disease. Individualized treatment strategies are essential, and probably the combined approach needs to be informed to the patients. PSMA PET is improving the stage accuracy, but a negative scan as of today does not exclude microscopic nodal disease. So PNLD is selected. It's a selective option. We have an extended lymph node dissection that provide a highest rate of staging. And in that line, we need to understand that there is obviously several options. So the to refine or decision making. So it's a combination of risk calculators, PSMA, and MRI that will probably make the best call. As of today, PSMA is not avoiding an indication for lymph node dissection. And with that, I thank you very much. And I really thank Ingrid for her big effort and the opportunity to having everybody there in Panama for this great meeting. Thank you.